Hello everybody. I'm sorry I'm unable to be with you in person to give this lecture at the EAU. I hope you have a great meeting. I'm going to be talking for the use of MRI in intermediate risk prostate cancer patients who are undergoing active surveillance. Here are my disclosures. Now, there are very few specific studies that have looked at the role of MRI in a highly selected subgroup of intermediate risk prostate cancer. So I'm going to try to approach the whole subject by looking at the ability of MRI to be a diagnostic, prognostic, predictive, or a monitoring biomarker. So we know that a diagnostic biomarker categorizes patients by the presence or absence of a disease or a subtype of disease. A prognostic biomarker tells you about the likely course of a disease usually in an untreated individual. A predictive biomarker categorizes patients by the likelihood of them responding to a particular treatment, in this particular instance, active surveillance. And a monitoring biomarker shows us what the biological response is in patients after receiving a particular intervention. So if we think about that framework and apply it to active surveillance, we have to ask different questions. So for a diagnostic biomarker, we have to ask, how good is MRI at selecting men with intermediate risk prostate cancer who are suitable or unsuitable for active surveillance? For the prognostic role, we have to ask, how good is MRI for men on active surveillance to decide whether we continue conservative therapy or escalate to active management? Regarding its predictive role, we're asking, does MRI promote oncological safety and long-term participation rates? And for monitoring, we are asking the question, how good is serial MRI ruling in and ruling out grade or volume upgrading during the active surveillance process? So we already recognize that there's a highly selected patient group with intermediate risk who are suitable for active surveillance. And you can see this EAU position paper already says that in the selection process, we should include a low extent on an MRI scan. So in a sense, it is already accepted as having a role. And this is because MRI scans depict different types of intermediate risk prostate cancer. So on the left, you can see a man who has Gleason 3+3 disease in the peripheral zone, a 3+4 tumour, more anterior in the left peripheral zone, and then a Gleason group 4+3 on the right-hand side. And you can see that these images show tumours that are in fact different. And if we look at surgical series, we notice that there are certain MRI features that are considered averse and certain features that are considered non-averse. And the most strong feature for a non-averse feature is in fact the non-visibility of a lesion on an MRI scan. And this is not really surprising when you look at biopsy yields by the visibility of a lesion using, say, PIRADS categories. So on the left-hand side, you can see a negative MR, non-visible lesion. Very, very few patients with grade group 3, for example. And then as the visibility increases, so you can see that not only is the proportion of clinically significant cancers increased, but also the proportion of grade group 3 and above also increases. In other words, it's prognostic. And this has been shown in a number of prospective long-term studies, that you can see how men who undergo definitive therapy and are followed for decades, patients who have non-visible disease, in fact, do the best in terms of low rates of metastatic disease and prostate cancer specific survival. And here's an example of one such patient with intermediate risk prostate cancer on the basis of bilateral disease and on a slightly raised PSA. And you can see that this man was followed for several years, after which, of course, the PSA went up and his grade group went up, and then he underwent definitive therapy. So you can see how the non-visibility of a lesion over time is in fact very prognostic of how this man would in fact do. And this has been shown in multiple surgical series. And here's a recent example. So these were men with favourable intermediate risk prostate cancer, and you can see if you had a positive MRI, you were much more likely to have adverse pathology on the prostatectomy specimens, so either T3A or T3B disease or lymph node positivity. And if you have a positive MRI, you're much more likely to undergo upgrading on the prostatectomy specimen. And in fact, this has been confirmed by other studies also, meaning that grade group 3 patients with visible PIRADS 4 and 5 in particular should not undergo a trial of active surveillance in men with even favourable intermediate risk prostate cancer. And here's an example of a man who was apparently suitable without the MRI on a systematic biopsy, and you can see that he had a red flag. And the red flag is, of course, the raised PSA and the raised PSA density. And when you do the MRI, you can see that there's a large anterior lesion. So what that means is that not only is MRI predictive, but in fact, probably PSA density is also predictive. And this was shown by this recent paper. And in this paper, you can see how the rate of upgrading increased with the PIRADS score and of course with PSA density. And if you had a PIRADS 3 appearance on a prostate MRI and you had a low PSA density, you were almost never going to be upgraded on a subsequent biopsy. Now this means that of course by doing MRI we will reduce eligibility in intermediate risk prostate cancer patients, and as you might imagine. And in fact, it turns out to be true. There's about a 10% reduction in the people considered eligible with MRI triage rather than systematic biopsy triage. And this means that there's a risk inflation. But on the other hand, you're actually promoting oncological safety in the people who are left because you got rid of cancers that shouldn't be undergoing active surveillance. So looking at the prognostic value of MRI, does baseline or confirmatory MRI with or without a biopsy identify men who in the future are more or less likely to experience a poor AS outcome? And in fact, this was looked at by the ASSIST study. So in the ASSIST study, there was a randomization by confirmatory biopsies being done either using systematic biopsies or an MRI targeted biopsy. And in fact, what you notice is that over 2 to 3 years following these biopsies, the MRI group had a 50% reduction in a future failure. So it seems like MRI, in fact, is predicting how patients will do in the future. In other words, its prognostic role. And here is an example. So this is a non-visible lesion in somebody who had 3+4 cancer on TURP chippings. He had a trust biopsy which showed just 3+3 cancer, had a confirmatory biopsy, again 3+3, and we followed him for several years, and he continues to do well on just active surveillance. So again, non-visibility is a really strong factor. The next question is, how good is MRI as a predictive biomarker? In other words, does it improve oncological safety and long-term participation rates? Well, there are no specific data in intermediate risk prostate cancer patients, but the answer is probably no, because of that risk inflation that we talked about earlier. In fact, if you can see how people who are diagnosed by MRI and then undergo active surveillance, still over the next 2 to 3 years, about 30% still undergo fall off active surveillance, meaning that MRI is in fact not improving participation rates of men on active surveillance. So how good is MRI at serial MRI at ruling in and ruling out upgrading or increases in tumor volume? And again, there's no specific data related to intermediate risk prostate cancer, but and here's a particular example of a man who has a small lesion. You can see how this lesion actually increases in size over a couple of years, and you can see the tumor volume on the right goes up from 0.25 cc's to 0.62 cc's, so it's tripled in volume. Now, how do we gauge these changes on MRI? Well, at the moment, we tend to use the precise grading, and so for a precise grade of 4, for example, is a significant increase in size or conspicuity of a lesion indicating some sort of cancer evolution occurring. So how good are these types of changes? Well, this was recently looked at in this systematic review, which looked at over 2,000 patients. And you'll see that the MRI suggested upgrading in about a third of patients, and about a third of patients, in fact, underwent upgrading. So you would think that they would match it. The MRI would show upgrading, and one in a third, and a third would also undergo upgrading. It turns out it's not the case. If you looked at a non-progressive MRI, so an MRI that was stable, how good was that at predicting the lack of upgrading, tumor upgrading? And it turns out it was not bad. So the true negatives were much larger as a proportion to the false negatives. However, if an MRI says that the lesion is worse, how often was there upgrading? And in fact, it turns out it's a 50-50. So in other words, serial MRI is more accurate at ruling out upgrading rather than ruling in upgrading, which should lead you to the conclusion that in fact you shouldn't be monitoring with MRI alone. You should be using MRI as part of a multi-parametric assessment with looking at baseline risk, PSA density, and clinical findings, and only when they are concordant should you be intervening. And this speaks to the use of MRI as something that occurs after clinical suspicion, not at the same time. So here are some general observations regarding MRI for AS monitoring. If patients undergo inclusion with a systematic biopsy, then many of the upgrades by an MRI biopsy is in fact due to sampling error corrections rather than true progression. If you used MRI for inclusion into AS, then any upgrades that you see are more likely to be microfocal grade group 2 cancers, and these people are of course still eligible for continued active surveillance. A stable negative MRI enables men to avoid a biopsy if PSA and PSA density kinetics and the clinical impression is concordant. But a stable positive MRI could be 50-50. But what we can say is that it's highly unlikely to be a grade group 3 or above. In other words, we are missing very few emergent serious cancers. So that's the reason why the EAU guidelines, in fact, endorse the use of MRI for active surveillance. In fact, you can see a number of recommendations in the latest guidelines of the EAU. So here are my final thoughts. Careful patient selections and surveillance protocols are needed to promote oncological safety in this slightly higher risk group, and it's these small subgroup with intermediate risk prostate cancer that you are trying to triage more carefully. I've tried to show you that MRI in fact identifies adverse features, so in fact it helps you improve patient selections. So it's acting as a diagnostic and a prognostic biomarker. Regarding its monitoring ability, MRI should be used with PSA and other biomarkers, and that should promote an MRI and an MRI directed biopsy in a risk-based and shared approach. You really shouldn't start treatment on the basis of an MRI alone without a resampling biopsy. Thank you very much for listening. I hope you enjoy your Congress.